Hey y'all, it's Professor Goodwin. Just wanted to talk to you about diabetes today. First semester nursing students, let's get into it, shall we? So, diabetes, you're already learning quite a bit about it in your world. And diabetes is an amazing process. We're going to learn about it. So, talking about slows, I want you to go through these in your book and make sure you understand these from your syllabus. These are going to be how you can guide your learning in this. And we have tied these also to your flows whenever possible. Okay, so go through those 10. And as always, this is a supplemental presentation, but as you can see, there's a separate slide deck that's directly from the book. Read the book, review those slides. This is intended to supplement that as well. Okay, so this is slow one. Explain the role of the pancreas in secreting insulin and glucagon to maintain serum glucose levels. So let's start with the two hormones that are primarily responsible for the homeostasis of blood glucose. Okay, you have insulin and glucagon. Insulin is released from the beta cells in the pancreas, and glucagon is released from the alpha cells in the pancreas. Okay, it's important you know that there's two sources. Glucose control arrives in the bloodstream from one of three sources: carbs that you eat by mouth, glucose released from stored glycogen in the muscles or liver cells, and then glucose that's newly created called glucogenesis in the liver or kidney. Okay, so that's an important concept to understand, that glucose can be produced or introduced into the bloodstream, and it's transported to target cells for energy, and it's released from the pancreatic beta cell. Okay, so when there's a disruption in the production of insulin, or what's called insulin deficiency, or when there are defects in the effective action of the insulin at the cell membrane, glucose can't effectively cross the cell membranes to enter the cell. And that's where glucose remains in the bloodstream and blood glucose levels rise above normal. Okay. Insulin facilitates the transport of glucose cells across the cell membrane. Inside the cell, it's metabolized as fuel, energy, right? The Krebs cycle, the ATP process. If blood glucose levels are high, the more insulin is secreted by the pancreas to take care of that. And then the blood glucose is driven into the cells and metabolized, and the glucose levels in the blood fall. Okay, that's the process. If the blood glucose goes too low, the insulin release is suppressed. The glucose remains in the bloodstream instead of being driven into the cells. All right. And in response to those low blood glucose levels, the liver and the pancreas start contributing. So glucagon is released from the pancreatic alpha cells, and glucagon stimulates production and release of glucose from the glycogen stores in the liver. Okay, so here's a picture of the way that happens. So the stimulus is me eating a cupcake, right? And so I'm going to commit carbicide, and I'm going to eat this, and it's going to go into my pancreas. The beta cells are going to release insulin in the blood to combat that increased blood glucose level. So the insulin, which by the way is a fairly caustic substance, as it turns out, it causes a lot of inflammation at high levels, goes into the body cells and the liver. The liver takes up the glucose and stores it as glycogen, and then the body cells take up the glucose. Okay, and the blood glucose levels decline because of the insulin. That creates a homeostasis, right? That's what a healthy body does. Then it goes to when the blood glucose level rises. Excuse me. That's one level. The second stimulus is blood glucose level falls, right? So when the blood glucose level falls, the alpha cells in the pancreas release glucagon. And so this glucagon goes to the liver. It breaks down glycogen and releases glucose. So that this is completely endogenous to our body, and it produces glucose. And so the blood glucose level rises. So this is how we manage high blood glucose, and this is how we manage low blood glucose, which creates homeostasis. Okay, so slow two, compare and contrast epidemiology, pathophysiology, and clinical manifestations of type 1 and type 2 diabetes. Okay, so diabetes mellitus, a group of disorders characterized by elevated blood glucose levels. 23 million people affected in the US. I'm sure it's higher, right? I think they've talked about 60% of adults in the US particularly are considered to be obese. So it's the major problem. Every public health agency is trying to manage this. And so, yeah, it's something that's hopefully we'll be able to manage in the future. There's two types of diabetes, as you probably already know, type 1 and type 2. All right. And then there's also gestational diabetes, which complicates 1 in 10 of all pregnancies. And so it's defined as any degree of glucose intolerance during pregnancy. Less common types of diabetes due to specific causes might be related to, let's say you have a pancreatic tumor, right? Or genetic defects in insulin action, you're on certain medications or chemical induced elevations in blood glucose. So those are all things that can cause it, but these aren't the typical causes because they are, that's an iatrogenic cause. Okay, type 1 diabetes mellitus. The epidemiology, this is the one where you commonly see it for people that are below age 30. It's become more common in type 2 as well, below 30, but it used to be if you were young and you had it, was probably type 1. And so it used to be called juvenile onset diabetes. This affects more than almost 500,000 children under the age of 14. It's triggered by an autoimmune response, and insulin producing beta cells of the pancreas are destroyed. Okay, so it's an autoimmune destruction of the beta cells, and it results ultimately in your inability to produce insulin. Okay, there's both genetic and environmental factors involved in type 1 diabetes. Environmental triggers can also play a part in genetic scenarios. In children and young adults, the process is usually pretty rapid, with a total insulin deficiency occurring within 1 year, and then lifelong injections are required. If the disease begins later in adulthood, the autoimmune destruction has a lot more variability in the way that it onsets and more of a slow time frame. The things you want to know about clinical manifestations, polyuria, that's increased volumes of urine, and that's due to an increased concentration of glucose in the urine. Okay. Hyperglycemia results in glucose excretion in the urine, which creates an osmotic effect that effectively reduces water reabsorption into the renal tubules, leading to excessive volume loss through the kidneys. And the way you manage this is type 1 is in the non-pregnant adult is diagnosed by different ways. Number one, the hemoglobin A1C is a very common test. Fasting blood glucoses can be done to see a snapshot of where you are. They can do an oral glucose tolerance test where you take pills and change your blood glucose and they measure that. Or you can do a random blood glucose, which is sometimes what we do. And the random has a wider margin of error than the fasting blood glucose. So usually they want you to fast, but you can take it any time. And then there's different ranges that should be allowable during that time. Oral administration of insulin is not effective because it's broken down during the second pass, the liver process. It's rendered ineffective during the digestion. So that's why we take injections. There are some different types of drugs that they're developing now, right? The GLP-1s and 2s, and those are things that you can use, and they have some oral forms of that, but that's not insulin. But it is a type of drug that are used to manage that. Okay, so diabetes type 2, let's talk about it. So it's a growing epidemic, obviously. In 2000, the prevalence was 3% of the population, but in adults, type 2 accounts for 95% of the cases, And at this point, being, that it's not 2000 anymore, it's almost a quarter of a century later, more than a quarter of a century, the prevalence of this is much, much higher. And it's one of the biggest public health problems in the world, and it has been for a long time. It's more common in adults than juveniles. It used to be called adult onset diabetes. And genetics and lifestyle are the two drivers of that. And we will call this glucose insensitivity or prediabetes. Those are all things that can be indicators of the fact that you are going towards having diabetes. And just something as simple as a 10% weight loss can have huge effects on this, or even just daily slow walking can reduce your glucose increase your glucose your insulin sensitivity. Okay, modifiable risk factors. Let's talk about that. So if your body mass index is greater than 26, if you don't have a lot of physical activity, if your HDLs are high, if your HDLs are low, your high density lipids lipoproteins are supposed to be high, right? Because that's sort of the carrier cholesterol, the stuff that can clean out the drain, that has to be high. But if it's low, then that can be a contributor, or a triglyceride level greater than 250. And then also metabolic syndromes. And that's what we're really talking about here. Metabolic syndrome has to do with the way that your glucose and your cholesterol and your diet intersect. Some non-modifiable risk factors would include, for instance, your first degree relative having diabetes, or certain ethnic populations have more common issues with diabetes than others. Women who deliver a baby weighing more than 9 pounds, or they were already diagnosed with gestational diabetes, pre-existing hypertension, women with polycystic ovary syndrome, or people with a hemoglobin greater than about 5.7 or 6. Okay, and then a history of cardiovascular disease in your family. There is a strong hereditary disposition for this. And prediabetes, we call it, it's a warning sign of the development. Okay, patho. So over time, the pancreas can't keep up with the increased demand for insulin. Beta cell failure appears and progresses. And really, the way I describe this is it's like when you're born, you have a debit card, right? And so you can keep taking that through, like I said, cupcakes and all that stuff. And I love cupcakes as much as anybody. But if your diet is comprised of a lot of sugars and not a lot of protein, then eventually that debit card is going to run out of money. And so as you get older, but it's a big debit card, so it might take you a long time, right? But if you continue to withdraw from that, what ends up happening is later in life, the beta cells start to fail. And during the later stages of this, insulin production declines, so that the patients with type 2 diabetes, they require, some of them require external insulin. Okay. Many of them don't. In fact, 70% of them don't, but that has to be managed with things like diet. And like I said, 10% of the weight loss can create dramatic changes and even cure diabetes type 2 in a lot of people based on their clinical presentation and their weight. Okay. So here's what happens. So if you have type 2 diabetes and you aren't taking external insulin and you aren't managing it, right, but it is high, those microvascular and macrovascular complications and insults to your kidneys and to your vasculature and circulation ultimately are complications of the long-term hyperglycemia. So it creates these problems that you can't feel, you can't see, you can't touch, but when the destruction is there, then the game's over. So management, what do we do? Well, we have oral medications that increase the production of insulin. They lower insulin resistance and slow the absorption of carbs. Management of both type 1 and type 2 requires the individual commitment to lifestyle. So even if you have type 1 and you're taking external insulin, you're still going to have to manage that very closely with your blood sugar, right? So many times they're either taking their own blood sugar frequently or they're wearing a monitoring device. But either way, what they eat is entirely important to what happens with their blood sugar. And so they're constantly thinking about that. So lifestyle choices in both regard are important. So consequently for us, education's huge for our patients, right? Tell them that diet and exercise and self-monitoring of your blood glucose and adherence to screening programs and weight management are huge. So that's what our job is, and that's one of the toughest jobs that a nurse has is trying to convince someone to make a change when they don't feel any kinds of problems related to it. But it often begins with nutrition therapy. So nutritionists are great for helping with this, and they can explain to them what different things are. Sometimes it's a knowledge deficit. Most times it's not. But people, with diabetes have a higher rate of depression and things like that as well. So that can help them. One of the things that, and people may not believe this, but just walking 150 minutes per week of moderate intensity or strength training, that kind of stuff can be very helpful. Now, obviously, if you're working out vigorously, like strength training or something like that, that's even better. But even just slow walks, 20 minutes a day can be very helpful for helping people with diabetes. Okay, so flow 3 is talking about explaining pre-diabetes and diabetes prevention. So what is pre-diabetes? Well, when the blood glucose is higher than normal, but not enough to be considered diabetes, which, this can be somewhere, and clinically, I don't remember what the guideline is, but let's say from 120 and above, right? 120 to 140. So a warning sign of this, indicating that type 2 diabetes may be developing is pre-diabetes, okay? So it starts to creep up, and we can keep an eye on that. The best way to manage that is hemoglobin A1C, and so because that gives you a longer snapshot. So if I were to eat a pancake breakfast right before I go in for my hemoglobin A1C, that would not drastically alter my results because hemoglobin A1C is over a longer period of time. Okay. If I was to take a fasting glucose or even a random glucose, which is the one where you can eat, and have that syrup and pancakes, my levels would be pretty high, right? Likely would be affected. And I said I didn't remember, but in the slide, fasting plasma glucose levels higher than or equal to 100, but less than 126 are considered to be pre-diabetes, okay? And sometimes what we'll do is we'll do a oral glucose challenge, also called an impaired glucose tolerance test. And so we will do that. Screening recommended for this situation every 3 years for all patients 45 and older. We pretty much do this all the time now. But we will draw labs, the hemoglobin A1C every 3 years, just as a general routine for patients that have the risk factors. If, like for instance, I have high lipid profile and low HDL, so had that I'm probably my whole life, but definitely since I was about 22. So that's just something that I screen for. Knock on wood, so far it hasn't transitioned to anything like pre-diabetes or anything, but I know pretty likely as I get older it will, because that debit card is going to run out someday. So the slow number 3, pre-diabetes and diabetes prevention. So the best thing you can do for pre-diabetes is weight loss, okay? Because it's going to lower your blood glucose levels. It's going to help your lipid levels and HDLs and all that stuff. It can reduce your hypertension. Even just a little bit of weight loss, even if you don't have hypertension, can help your heart work more effectively. And so that helps your circulation. And on a micro level, that still matters, right? Even though you might not even see it on your blood pressure. So the improved dietary habits are huge. And the best way to do that is to watch your carbohydrates. Okay. There's some new information that says that fats aren't as terrible as we like to think they are, but ultimately, the most efficient meal that you can have and is protein based food, right? And vegetables. Vegetables will raise your HDLs, and protein your body can turn into muscle. And it's a little bit more difficult to turn protein into glucose than it is for fat or carbohydrates. So you want them to stick with as much protein, lots of water, lots of vegetables. Smoking cessation. Smoking is not going to do you any good either. It contributes to this. It can make things worse. Alcohol consumption can also do that. And you want to try to encourage regular exercise. Okay, so slow number 4, compare and contrast medical management of type 1 and type 2 diabetes. So the signs and symptoms. So when we see somebody and we have a new diagnosis, the type 1 is going to show you the 3 Ps, but also is type 2. Okay, so the 3 Ps, polyuria, that's an increase of volume of urine. Okay, and that's an increased concentration of glucose in the urine, also called glucosuria. The hyperglycemia results in glucose excretion in the urine. Okay, and that leads to excessive fluid loss. That's one of the reasons that you can take a urine test to test for diabetes. We'll talk about that. For hyperglycemia, it also causes a shift in the fluid from the intracellular space to the vascular space. Okay, the loss of this intracellular water combined with the volume loss of the kidneys creates excessive thirst in the patient. All right, so next we'll talk about polydipsia, the second P, excessive thirst. And then finally, polyphagia, increased appetite. The lack of insulin necessary to move the glucose into the cell leads to a breakdown of proteins and fat as a source of energy, okay? And so this starvation of the cells leads to increased appetite. So that's part of this metabolic syndrome we talked about, okay? It's a dysfunction inside the cell of your ability to produce energy, which ultimately stimulates your hunger more than what would be if you didn't have that metabolic syndrome. So this starts to touch on things that aren't necessarily proven in research yet, but that I believe is that there's a distinct difference between someone with a metabolic syndrome and the way that they experience hunger than people that don't. And I think that we're starting to see that. Okay, so the one thing about type 1, you're gonna be losing weight and you're gonna have fatigue. Okay, so usually these are people they're actually very thin and they tell you they have diabetes, and if you don't know the difference between the two, you're thinking, well, gosh, you don't seem to be overweight. That's really strange. That's because it's a different type of situation. In the type 2, you're gonna have fatigue, but you'll also have blurred vision because of the micro insults to your vasculature. You'll also, which means that there's damage happening, poor wound healing, as long, depending on how long it's progressed, cardiovascular disease because of that circulation, renal insufficiency because we've talked the fact that your kidneys are really sensitive to minor insults and changes in your blood pressure and your circulation. And then finally, recurring infections. So a lot of times you won't have the ability to fight off infections the way that you once were able to, because this creates an overall reduced efficiency in your ability to manage circulation. Okay. How do we diagnose? We talked about this earlier. Hemoglobin A1C, that gives a 6 to 12 week snapshot in time. And so this measures the average blood glucose over time by measuring the amount of glucose that binds to RBCs. All right. So this is the gold standard in figuring out how you're doing on your blood glucose. And you can't manage your blood glucose for 3 days before you take it and expect it to change. Fasting blood glucose levels is another way we take it, which means you haven't eaten within 8 hours. We have a 2-hour postprandial blood level, so that'll be something 2 hours. It's carefully measured after you have eaten to determine how your body is responding from an insulin perspective. And then finally, random glucose levels, which you can take any time of the day, and the parameters are a little bit looser and see where your body's at. The bottom line is we talked about those two ways of hemostasis, where your homeostasis, where your body manages the glucose going up and it manages it going down. And so the random blood glucose level tests how your body is managing that process. Okay. So like I said before, treatment on both cases, it's all about nutrition. For type 1, it's about nutrition management and understanding what exercise, which reduces blood sugar, and eating, which raises blood sugar, how those interact, right? So patient education and self-management is a huge part of it. It's really difficult for people that are newly diagnosed. This is a huge change in their life. And so it's not uncommon to see that they don't manage it well, and they may be depressed about it and things like that. So they're going to be monitored for complications, and they're going to be on insulin therapy. Sometimes when they're young, they might even find that the way they find out is that they have some major issue. They end up in the hospital with insulin level of 350. And so that's how they find out. And then, oh gosh, okay, I have this new health condition that I'm going to have to drastically change my life for. And it's hard. Type 2, that's something that you find out when you go to your primary care physician usually, or maybe you go to the hospital for something else and they test it and they tell you that you have it. Education is huge. Nutrition is huge. Monitoring your glycemic control is great. Exercise is going to help you. And then keeping an eye on monitoring for complications, just like type 1. But sometimes we can use oral drug therapy and also insulin if necessary. Okay, like I said before, the self-management part is a big deal. For both, education is going to be a huge part of it. Nutrition therapy is going to be helpful, and diabetes educators are helpful for that. But meal planning is going to be something that they have to learn about. For diabetes type 2 people, some of us nurses feel a little bit more comfortable about how to communicate that, but nutritionists can be great about, particularly with type 1, about how to manage your portion sizes and your food selections. So don't hesitate, even if you're going to help a little bit at the bedside, don't hesitate to reach out to nutrition and get a consult to help them. It might ultimately increase their adherence to their protocol. Exercise, if you can encourage that, is a huge part of it, and which will result in weight control. And also, a psychosocial assessment is important. All right. Like I said, depression is a common factor and a common thing that's experienced, and it relates to non-adherence. So people just throw up their hands and say, "I will forget it. I'm just going to pretend like it's not there," and that usually ends badly. And then there's, like I said, a lot of great tools for blood glucose management and monitoring. And so you just want to try to get them to adhere to some sort of screening program and look for complications as they go along, because this is a new disease type for them. So they can do self-monitoring. That's a situation where you stick your finger several times a day. They have those monitors on the back of your arm that are really great. I can't remember what they're called off the top of my head, but very expensive. So if your insurance is not paying for it right now, they're pretty expensive. And then we can monitor hemoglobin A1C to see what the 6 to 12 week picture looks like. All right, so we are going to monitor carbs, and that they do that through carb counting or exchanges. So they use different methods to do that. And the carbs, it's really the key strategy is watching your carbs. Okay, and insulin also plays into that, depending on what your genetic scenario is, whether you're type 1 or type 2. Oh, one other thing. So sometimes people are unwilling to count carbs. Sometimes what they can do is, as a substitution, they can just narrow their food plan and only certain types of foods and certain meal plans, and that can also be helpful. It's less, ultimately it's less satisfying to the patient and maybe decreases their overall long-term success with this, but sometimes it's a good first step to get people to control their eating, and then they can maybe take it on later. Okay, like I said before, 10% of the body weight, if you can lose that, can have a huge impact on your insulin. So you have to balance that lower fat and calorie consumption with regular fitness and exercise. All right, so both of those things have to be in place, but they can be quite effective when they are. And even if you're not losing weight, exercise can be of benefit. I think I've hammered that home. Physical activity. So it can also increase your sleep quality. A lot of people don't know that. That can be helpful. And it can decrease your risk for every mortality risk, okay, as well as depression. So helpful for anybody that is stuck in a rut, and can help you get unstuck. What they recommend is 150 minutes a week of minimum of moderate intensity exercise, okay? So it says here may cause hypoglycemia if the insulin dose or carbohydrate intake is not adjusted. So what this really refers to is the situation where I'm a new diabetic and I am taking insulin of type 1, and I decide I don't want to eat my food, but I've already taken my insulin, right? Or maybe I didn't plan on exercising, so I took a certain insulin based on my blood glucose, but then I go out and I run for a while. So that can create a situation that's hypoglycemic, and that can be very dangerous as well. So the management isn't just about keeping it high or keeping it low, it's also about keeping it above a certain level. Okay, we talked about the psychosocial assessment and why that's so important. All right, so let's get into etiology, clinical manifestations, and management of hypo and hyperglycemia. Okay. All right, so hypoglycemia we're talking about here. The etiology, really what it is a blood glucose less than 65. Okay, so when you're in the clinical environment, you draw something that's less than 65, you're starting to realize that you have to do something immediately. What it happens is when there's more circulating insulin that's needed than is needed, brings the blood glucose too low. The manifestations of this, the patients might be really helpful with this. They will be the ones to tell you sometimes that they feel like their blood sugar is low. Interestingly enough, service animals can be trained to sense this, which is amazing. But another reason why dogs are awesome. Clinical manifestations include anxiety, hunger, palpitations, numbness around the lips, sweating, shakiness, irritability. If you guys are, most of you are pretty young, you probably haven't felt this, but as I've gotten a little older, what I've started noticing is if I have a really high sugar meal, I can feel some of these things. So I don't like that feeling, right? So I try to limit that. And I love all the sweet stuff, but if I'm going to have like a pancake, if I'm going to have pancakes, I'll, instead of having like a huge, IHOP cinnamon, whatever it's called, the icing and all that kind of stuff. Instead of having that, I'll have like one pancake and an omelet, right? And so that will usually keep me from feeling crummy about experiencing some of these things. And I don't even have diabetes, right? So that's the way it can feel for anybody. Okay, so if these blood glucose levels continue to drop, what ends up happening is the CNS is inadequately supplied with glucose. So it can cause fuzzy thinking, dizziness, fatigue, sleepiness, slurred speech, and weakness and lack of coordination. This is an emergency, okay? If this is untreated and it progresses further, it can cause a seizure or a coma. So if you get a result that's, 45 in a patient, you need to do something right now. And so usually what happens is if they're alert and, it doesn't mean they're going to stay that way. So this has to happen pretty quickly. You can potentially just go get them some juice, right? Or if they're obtunded and they're not conscious anymore, you have a very serious situation, but you can inject glucose into their veins. The other thing too you want to keep in mind is that um, the hospital may have protocols that you want to follow. Okay, like I said, you're going to administer oral glucose pills, for instance, 15 to 20 grams to raise the levels. Juice, soda, honey, jelly, bread, crackers. These are all things that are quickly absorbed to change that. If you want to avoid carbs that have a lot of fat because it will just delay the absorption. After the ingestion of carbs, you should measure the glucose level within 15 minutes and then repeat that treatment. Be careful of the situation where you have a rebound hyperglycemia, right? And so what ends up happening is you give them whatever this is. Maybe you give them 3 cups of juice, and now all of a sudden you're chasing the high blood glucose, right? So you want to be measured enough to keep them back to a safe level, but don't overdo it. Okay, let's talk about hyperglycemia. This is the high blood glucose. So sometimes diabetics that have had this for a long time, they may not show these symptoms anymore. Okay, so you have to be aware that some people will not experience these later, but some people will. Early signs, we talk about the polyuria, polydipsia, right? And polyphagia, blurred vision, fatigue, and headaches. The later symptoms, these are a little bit more associated with a more severe situation like diabetic ketoacidosis, blood glucose levels that are higher than 200-300, and that can become much more serious situation. Ketones build up in the blood and urine, and that causes ketoacidosis as a result of the untreated hyperglycemia. So the symptoms would include a fruity smelling breath, believe it or not, kind of like what do you call that? Fruit. What's the name of that juice? The gum fruit, juicy fruit. Yeah, and they might have nausea or vomiting, shortness of breath, dry mouth, weakness, confusion, coma, or abdominal pain. Now, anytime somebody has some confusion or a coma or any change of a level of consciousness, you're talking about a later stage symptom, and that's something that you need to take very seriously. Okay, long-term complications. When you have hyperglycemia in whether it's type 1 or type 2, you're going to have some health problems from it, okay? So one of the things that you might see is autonomic neuropathy. We call it just neuropathy, but what it can look like is, number one, is diabetic gastroparesis. So your gut stops working as much. It's less effective. So it moves your food through your stomach slower, okay? You might have erectile dysfunction, orthostatic hypertension. So a change of elevations, you're going to have high blood pressure, and then also urinary problems related to your kidneys. So the long-term responses related to the depressed immune response can lead to infection and poor wound healing. And it's an acute complication of hyperglycemia, okay? So your body's less able to fight infections due to that state. It can also damage the large arteries, and that puts you more at risk for cardiovascular disease and stroke. Other things that can be the result is diabetic retinopathy. I told you that in your eyes, when you have the blurred vision, that's a micro insult to your vasculature in your eyes. Over time, that can cause a retinopathy or blindness. Periodontal disease. So your gums are very vascular, and so if there's a reduced ability to perfuse that area, you might see an increase in tooth decay or death. peripheral vascular disease and renal failure. So the kidneys and the external limbs, they can't perfuse as well. And so what that ends up causing is peripheral neuropathy and other problems with circulation. And the kidneys, whenever you change your circulation or blood pressure adversely, it affects their ability to filter the blood and ultimately makes it work harder. That's why people ultimately end up on dialysis if they don't manage it well. Okay, slope 7. Describe the assessment, nursing diagnosis, interventions, and evaluation for clients with type 1 and 2. So we talked about the 3 Ps. The nursing diagnosis that you're going to have with this, impaired tissue perfusion. That's usually a good one. And the risk for neurological impairment. I think that's pretty obvious, hopefully, because of what we've discussed. Interventions. So now that you've identified that, assessments are going to include your vital signs, your subjective discussion with them, serum glucose levels, other metabolic panel, things like potassium levels. You're going to manage their I's and O's well, and also keep an eye on their carbohydrate intake meals. And they might be on what's called a diabetic diet. Actions, the bedside glucose monitoring. You're probably already doing that, right? And you're managing the insulin administration. You're also probably getting certain fluids that might be different from somebody that doesn't have diabetes in the hospital. Maybe you're giving them normal saline instead of lactated ringers, things like that, okay? The teaching, you're just going to teach them what the signs of hypo and hyper are, what they are, and teach them about their sub-Q insulin administration because they're going to be giving it to themselves most likely unless they have a pump or something like that. And even in that case, there's education involved. And then you're going to teach them about blood glucose monitoring and then healthy lifestyle choices. Okay, so exchange lists, like I said, with nutrition, they can help you with that. Nutrition labels, they might need you to help them understand how to keep track of their carbs, where you can find that on the nutrition label, things like that. What's healthy, what's not. I told a story to the class about my mother-in-law. When we were younger, our kids, we tried to minimize their sugar intake. And my mother-in-law was telling me about how she was having them drink a protein drink, but it was one of those Odwalla green juice ones that have like 45 carbs and 8 grams of protein. So for her, that was a protein drink. For me, it was that was a much different situation. And so some people have that baseline of knowledge, and so you can hopefully help them see that that's not necessarily going to help them. And there's all these different situations that you can point them towards, and alcohol consumption is one of the big points to say stay away from that because alcohol is ultimately it's glucose, right? Okay, type 2, same thing, 3 Ps, right? They're going to have poor wound healing, maybe cardiovascular progression, visual disturbances, renal insufficiency, recurrent infection. So for these guys, the risk of ineffective tissue perfusion and ineffective renal perfusion, right? Both of those are problems. And then the risk for infection can be their diagnosis. Interventions, same thing. You're going to be, managing the intake, managing the level of glucose, watching their perfusion of their limbs. You can also take a look at their WBCs, see if there's an infection, BUN and creatinine levels, which tell you what the kidney is doing. And then you can do things like, spot urine for microalbuminuria and carbohydrate intake at meals. So you're going to see the same things as before. Sometimes you might see them on antibiotics to help them if they do have an infection. And education is all going to be about the same type of stuff. What you might see them on also is foot care, depending on how far it's progressed and things like that. Okay. All right. So differences between rapid and long-acting insulins. We're going to talk about indications, onset, peak, and duration. So this table is in your book. If not, there's one just like it. So you have your fast acting or rapid acting insulins here, right? You have the Humalog, Lispro, Novolog, and Apidra. I don't think we use that very often, but anyway, here's the lift. Now you can see that the onset is pretty fast, right? So it's on fast, it peaks fast, and it's short in duration. Okay, these are the ones that you use right after a meal or something like that. Okay, the short acting, and these are also used pretty frequently as well, is the regular Humulin or Novolin. Okay, these are 30 minutes onset, 2 to 5 hours, a little bit longer, and longer duration. Okay, sometimes they'll use the intermediate or the long acting. Now, what that serves, the purpose it serves is that there's a little bit more long-term consistent management of that. So the reason that would be important is if you have somebody that has well, they used to call them brittle diabetics, right? It was hard to manage them. And so what would be useful is for you to have a baseline, like let's say their blood glucose rides up here, and really what it does is it goes like this, right? But it's all high. You can knock that down to a more normal level and then manage the peaks with the regular insulin, right? So that's what they're doing when they're ordering the longer acting ones. In addition to that, they will be given together a lot of times. And we always give insulin in units of insulin, and so that's per milliliter. It's given in an insulin syringe. Okay, so 1 milliliter is 100 units, 0.3 milliliters is 30 units. You get the idea. And you're going to choose the size based on the amount of insulin. Usually it's going to be less than 1 milliliter. Okay, there is one that's 500 available by special order, but most likely you're not going to be giving those. So anytime you're giving insulin, it's in units and oftentimes it's less than 10. So just be aware that's a very sensitive medication to give. The dosages are very small. So if you have a dosage that's high, that's an indication that you might need to double check it. Okay, so the use of basal and bolus insulin therapy to control blood sugars. All right, so the use of short-acting insulin to prevent a rise in blood glucose after eating meals and the addition of long acting, as we were just talking about, can help you keep a more steady blood glucose level. So what we do is we have what's called basal insulin. Okay, so we'll give that to, and when I was talking about up here and knocking that down, that's the basal insulin. And then you have the bolus insulin, which is the regular insulin that you hit and that knocks it back down as well, right? And ultimately, both of those ideally create more of a steady blood glucose that's within normal limits. Very difficult to do with managing this, but in the hospital, we manage it closely. All right. So basal is usually administered once or twice a day. Nutritional is the rapid acting and short acting that covers the incoming carbs. And then correctional is a sliding scale. So you'll have this as well. So it'll say if the blood glucose is 200 to 250, it's going to be 8 units. If it's 251 to 300, it's going to be 10 units. So on a sliding scale based on how their glucose works, that's when you'll see that. All right, and here's an example of that. Notice at the bottom, glucose greater than 400, hold insulin and call MD stat, right? Because they're going into ketoacidosis. Okay, methods of insulin delivery, appropriate sites. So how do we deliver insulin? We did this in our pharmacology lecture, but you want to make sure you rotate the sites and you want to choose your syringe correctly. And you want to make sure that you have infection control practices appropriate with the injection sites, okay, and the proper technique. All right, so now we're going to talk about oral anti-diabetic agents. So you might have heard of these. So the metformins of the world, the sulfonylureas, and all of these down here you'll see. And then also what you could add to that is the GLP-1s and things like that. Okay, so here's a chart of the mechanism of action of each of these things. So for instance, the metformin, which is the most common one, decreases glucose production in the liver, okay? and that helps increase insulin sensitivity in skeletal muscle. And one thing you want to be aware of is that it can cause two things: cause diarrhea when you first start taking it, and it also can cause renal impairment in kidney compromised patients. Okay. So these are all different medications that you would go through with the patient, and they all have different effects. Okay, so incretin mimetics, these are a new class of anti-diabetes drugs that involve modulation in the incretin system. They bind to and activate glucagon-like peptides, so GLP-1s. And what they do is they inhibit insulin secretion, and they also slow the gastric motility, which ultimately helps you manage this metabolic syndrome better. Okay. And then the SLG2 inhibitors, these are pills, and these prevent glucose from being absorbed by the kidneys. Okay, let's take some questions. So the nurses just administered the morning dose of Lispro, also known as Humalog insulin. Just after the injection, the dietary department calls to inform the patient the breakfast trays will be 45 minutes late. Change in the intake, right? What will be the nurse doing next? Number one, inform the patient of the delay. Number two, check the patient's blood glucose levels. Three, call the dietary department to send a tray immediately. And four, give the patient food such as cereal and skim milk and juice. What do you guys think? Well, we can certainly inform the patient, but that's not going to do anything to help with this. We can check their blood glucose levels. We can do that, but what we know is that they need some intake. We can call dietary to send a tray immediately. You can do that. But the best answer of these, Lizpro's insulin onset is 15 minutes. So very quickly, you're going to have to eat a meal. Otherwise, you might be at risk for hypoglycemia. So we're going to give the patient some food. I'm going to bite the bullet and just manage it as best we can after that, and hopefully do better the next meal. A male patient who has a history of type 2 diabetes is admitted to the medical unit with a diagnosis of pneumonia. The patient has many questions regarding his care and asks the nurse why everyone keeps telling him about hemoglobin A1C. What can the nurse inform the patient about the use of hemoglobin A1C in diabetes mellitus? It helps identify which type of diabetes you have. We know that's not true because it doesn't do that, right? We'll identify if he has an infection. I don't think that's true either. We'll aid in monitoring patient compliance with treatment over several months previously, or represents current fasting blood glucose levels. Well, C is what we've talked about, right? It's a good indicator of the patient's compliance over several months. The current fasting blood glucose level will give you a snapshot of that day. Okay, so that's everything. I'm going to put this up for you, and I hope you have enjoyed the diabetes lecture. Don't forget to like and subscribe. Just kidding. Good to talk to you, and good luck.